blood and marrow. Dr. Orchard completed his medical degree at Brown, did residency at the University of Wisconsin-Madison, and then came here to the University of Minnesota to do his fellowship in HEMONC and BMT. And has been stuck here ever since, and we are so lucky that he has. He really became interested in rare diseases over 20 years ago and partnered with our neurologists and leaders in our BMT division, such as Dr. Krivet, and has really made a career and been a leader both in specific rare diseases such as the leukodystrophies, but also as one of the things I found so inspiring is seeing how he partners with community members, families who are championing rare diseases and how we can do better for all kids with rare diseases. So I'm really excited to welcome him here today and kind of catch us all up on what's going on with leukodystrophies and how we can do better. Welcome, Dr. Orchard.
Great, Emily. I appreciate that introduction, and it's great to have the opportunity to talk to people today about the leukodystrophies. So Emily and I were kind of chatting a little bit before we got started about how these things got off the ground. And yeah, there's a number of really pillars in this field that were here, and it got me kind of going 20 years ago or so. Bill Krivet was one of those. Elsa Shapiro in the neuropsychology group was one of those, and then and Bill Dobbins was around at around that time. Larry Charnas on the neurology side. So it was great discussions about what these diseases are looking like, what the biology is associated with them, and what we can do to help these kids. So the University of Minnesota really has been a pioneering group in developing therapies for these patients and understanding what's going on with them. So I'm happy to be a part of that. Oops. How do I move this forward here? There we go. So in terms of disclosures, so there's a number of companies that we've worked with. Many of them are in association with clinical trials. I also serve as a consultant for some of these groups. And I'm going to talk a little bit about Orchard Therapeutics, which I have to always say is not my company, but it's a group that we've partnered with on developing some of these therapies and potentially instituting them more broadly. And so some of the therapies we'll talk about a bit later are still in development and are off-label. So what I'd like to talk about today are primarily three diseases: metachromatic leukodystrophy, Krabbe, which is globoid cell leukodystrophy, and adrenal leukodystrophy. I could talk a little bit about the diagnoses of these diseases, some of the obstacles to diagnosis related to that, newborn screening, and then we'll get into some of the therapies. Allogeneic transplant has been used since the 80s, actually, for some of these disorders. And, as a transplanter, it's become clear to me that we need something better. And there's a lot of discussion now about other agents, including gene therapy, and we're going to touch on all those and then what the implications of these things may end up being. So just to put these into perspective, so there's about 7,000 rare diseases, and the definition of a rare disease is less than 200,000 people affected by that in the United States. So individually, these diseases, of course, are rare, but globally, they make a big difference in terms of society. And in terms of costs to the society, there's a group called Every Life that did an analysis of some of these costs, and it was about $1 trillion per year. So leukodystrophies are, as you might expect, a subset of the rare diseases. And for instance, metachromatic leukodystrophy is a subset of the inherited leukodystrophies. The incidence is about 1 in 40,000. And being as there's about 4 million kids born in the US every year, there's 100 kids roughly that would be affected with MLD. So I want to expand a little bit on this importance of these diseases in society. And again, Every Life is an advocacy group that's interested in rare diseases. They did an analysis of the cost to society and to the families. in 2019. And there was 379 diseases that they looked at. So again, kind of a small subset. But the red balloons here are the direct costs, inpatient, outpatient costs, for instance. The orange balloons are indirect costs in terms of productivity. Absenteeism would be either providers that couldn't go to work or contribute, or the patients themselves in the situation where they're adults. Presenteeism essentially is if you're at work but you can't function fully, and the loss of the ability to accomplish what you're working on. And then a number of people are forced to retire early, so that's in here as well. And then the uncovered costs are in purple. So this is the global situation. Here, the costs are broken out on a per patient basis. The top bar is related to pediatric population, and the lower bar, the adult population. And as you can see, the number of the costs to a family, for instance, are very significant by having a patient affected by rare disease in the family. So what diseases are we focusing on here? We'll start with metachromatic leukodystrophy. So the leukodystrophies essentially means the white matter of the brain is affected. And in some of these diseases, MLD and GLD that we'll talk about in a minute, there's demyelination centrally, and there's also peripheral nerve demyelination as well. And both of those things can affect patients and manifest the disease in potentially different ways. In this circumstances, an autosomal recessive disease, it's aryl sulfatase A is the enzyme deficiency. In this circumstance, they accumulate sulfatides, which is really a substrate. Those can damage, again, both the nerves peripherally and centrally. The disease is progressive and ultimately lethal. It's important to understand that even within this enzyme deficiency, there's a number of phenotypes. The most common one is the late infantile form. So this affects kids in the toddler age group, generally speaking. So the definition is the kids that are affected clinically by less than 30 months of age. And these kids tend to have issues that are related to initially gross motor and then ultimately fine motor problems. The juvenile form is from 30 months to 16 years. This is pretty commonly broken into an early juvenile form and a late juvenile form. And again, there's cognitive issues associated with this, but primarily the kids present with motor-related problems. In contrast, there are also adults that present with MLD, and they tend not to have the motor-related problems so much, but they have executive function problems. So some of them are substance abuse, some are getting into gambling and other sort of destructive issues. So that's the way that those patients are generally picked up. And this just provides a little bit of information in terms of the peripheral nerve issues. And I just wanted to point out that in MLD, the late infantile patients, which are the blue bars here, have quite significant peripheral disease, which is very important in how these patients manifest their disease and progress. The early juvenile patients here are in orange, late juvenile in green, and the adult form, again, motor issues are not so much of a problem in that population. So globoid cell leukodystrophy, or CRAB-A, again, is an autosomal recessive enzyme deficiency. And here the enzyme is galactocerebrosidase, and the substrates that accumulate are galactocerebrosid, galactosphingosine, tripping over that, and psychosine actually is probably the key one. And psychosine is the one that has really been important, as described recently, in helping determine what the phenotypes are going to be. Again, the disease is progressive and lethal. There's several different phenotypes associated with GLD as well. Again, the more common ones are manifest early. The infantile form are the kids that have symptoms within 36 months of birth. Most of these patients are diagnosed quite early and can be severely affected in the first year of life. Sometimes at 6-8 months of age are quite symptomatic. There is an attenuated form as well that we see less commonly. But generally, it's the infantile form that the patients that come to us. There is some newborn screening available in some states for GLD, and we'll talk about this a bit later. There is no newborn screening yet available for MLD. And ALD we'll touch on as well a little bit later. So ALD is the third disorder we're going to talk about today. So this is somewhat different. So this is X-linked as opposed to autosomal recessive, as the other disorders are. The frequency is about 1 in 17,000 boys. This is related to the ABCD1 gene. The ABCD1 gene is not an enzyme like is seen in GLD and MLD. It's present in the peroxisomal membrane. It takes very long chain fatty acids and shuttles them into the peroxisome. And if that gene product is not there, not functional, the very long chain fatty acids are not degraded and they tend to accumulate and they add additional carbons on. So plasma levels of very long chain fatty acids is the diagnostic tool that we use to identify patients with this disease. Newborn screening has been available for this and has made a significant difference, and we'll explore that a little later. There's also phenotypes associated with ALD. The one that we see primarily is the cerebral form. So this is the more severe form of the disease. It happens to about 40% of patients up to age 21. It's not associated with the genotype. And so there are families where there's a number of individuals that have the same mutation, but they don't have the same phenotype. And the reasons for that are still unclear. There are several other manifestations of the disease. The Addisonian side of the adrenal insufficiency is present in a large proportion of patients, and that can happen quite early. And there's what we call the adult form or adrenal neuropathy, which happens as patients get into their third, fourth decade of life. And that is quite prevalent. So you can have any of these phenotypes present or all of them. So it makes the identification of these important and in terms of the patient care. And this just shows that patients, when they're born, have really no manifestations of the disease. So they accumulate very long chain fatty acids. You can detect that at birth, but these patients are all asymptomatic initially. And then over time, they tend to develop one or more of these phenotypes. By the time you're 40 or so, virtually everybody has clinical aspects of the disease. And this is another interesting aspect of the disease, is that there are peaks in terms of the cerebral form, and clinical disease peaks at about age 7 in the pediatric population, and there may be another smaller spike in adulthood. But again, we have no way of anticipating which kids are going to get affected by cerebral disease. And as I mentioned, throughout a family, the variation in phenotypes can be significant. Just to show a bit about what this looks like on MRI, most of this disease starts in the area of the corpus callosum or splenium and the occipital part of the brain and spreads from there. So that's the typical pattern that we see. As the disease progresses, these boys tend to have issues with auditory processing, understanding language. They can have problems with vision. Usually it's peripheral vision to start and then becomes progressively worse from there. So some of these boys are picked up because of attention deficits in school or handwriting problems, because they don't understand the teacher. and they continuously or they progress to the point where they are just not functioning well. Interestingly, this is a neuroinflammatory disease, and so if you give gadolinium, characteristically, the patients show gadolinium enhancement. So we understand this is that the areas of inflammation lead to breakdown of the blood-brain barrier, and that's what's associated with this gadolinium enhancement. So when we see enhancement like that, we interpret that as signs of active neuroinflammation. This is what the untreated curve looks like for patients with cerebral disease. So survival at 5 years is 66%, but again, it's progressive. These kids can become increasingly debilitated, and you can maintain them alive with G-tubes and feedings and whatnot, but they essentially get to a vegetative state and eventually die. In terms of diagnosis, as I mentioned, MLD and Krabbe are lysosomal disorders and are autosomal recessive. So generally, there's no family history, although sometimes these patients are picked up and they have younger siblings that you can then identify maybe yet asymptomatic. So when we're working up these patients, the enzyme deficiencies become apparent. That's relatively straightforward to test for. Usually we look at the genotypes as well, identify the mutations. Those can be characteristic of phenotypes in a lot of circumstances, although not ALD, but we'll get to that. But these accumulate substrates. So in the terms of MLD, sulfatide is what accumulates and ends up being toxic, and cycosine in the case of GLD. ALD, again, in contrast, is peroxisomal, X-linked. So sometimes there's a significant family history in patients with ALD. And again, it's not an enzyme deficiency, but a peroxisomal membrane issue associated with very long chain fatty acid elevation. And there's a relatively newer assay, the C26 lyso-PC assay, which is used in newborn screening. I wanted to talk a little bit about the nuts and bolts of the diagnosis, because some of these rare diseases are difficult to diagnose, and this ends up making a big difference in terms of both the medical side, but especially on the family side. And so this is what we term the diagnostic odyssey for some of these rare diseases. So this is not specific to any of the leukodystrophies, although we'll talk about MLD here in a minute, but it just gives you a perspective that there's a number of primary care providers that are seen, specialists seen. These kids can be in and out of the hospital and in the emergency room. A number of these families travel out of state to find people that might help them in diagnosis. And so this is a major difficulty that we see in trying to get these patients correctly diagnosed so they can be treated. So this is from a paper specifically in terms of MLD. Some of the symptoms may be quite nonspecific early on, and the misdiagnosis can certainly happen. Sometimes the interpretation is that the patient just isn't developing as well as the siblings are, but there's variation in that. Sometimes they may be termed as having cerebral palsy or other issues. But even in MLD and late infantile MLD, which is quite rapidly progressive, the average time to diagnosis from the first onset of symptoms can be 1.2 years. And many of these kids with late infantile MLD die by the time they're 3. So for juvenile disease, which has an onset clinically a bit later and progresses slower, the time to diagnosis is even longer. And this ends up being key because the opportunity to actually have some intervention that's meaningful for these patients is dependent on being able to identify these patients early. And if they're diagnosed quite late because of the progression that's already occurred, much of this damage, the demyelination, is irreversible. And this just provides a bit of a timeline in terms of what's been described in MLD. So this is looking at the late infantile form. But on the top part here, the gross motor function, some of these kids are developing, starting to walk, maybe never master that, and then actually start to lose ground. And so rather than becoming more proficient at their gait, they're deteriorating, and then lose the ability to balance, stand, and then have progressive gross motor skills, or loss of gross motor skills. Fine motor skills tends to be more apparent a bit later, and the aphasia that develops and whatnot too. So again, just to provide some sense of what the disease progression looks like and how long it takes to get them diagnosed. And just to map this out a bit, so if you have a patient that has the onset of symptoms, generally they see their provider. A lot of times there's some reassurance that's provided that we'll watch this for a little while and see where this is going to go. And, this is clearly understandable, but this is part of the issue that's associated with the diagnosis here. At some point, it becomes clear that something is off. They're referred to a specialist. Sometimes getting in to see the specialist can take an extended period of time. That person may begin some testing, but some of the testing may be sequential, and that may take an extended period of time. The patients may be in and out of the emergency room or even being hospitalized along this course. Eventually, there's a different specialist that may be brought in, and other testing that might be done. And then finally, diagnosis is established. So it could be a long, difficult road in making the final diagnosis. I want to talk a little bit about newborn screening and its role here. And one of the points I really want to make is that the families are very important in development of some of these interventions and better understanding the disease. So, PKU is kind of the prototype in terms of newborn screening. But in 1934, it was a Norwegian mother that really pushed to help understand why her child was affected. It led to the discovery of PKU. It was a mother in the UK who really pushed for therapy for patients with PKU, and that led to the creation of the specific formulas that we now use for the disease. In 1957, there's a family in California that pushed hard to develop a means of diagnosing PKU. And after that, Robert Guthrie, who actually trained in Minnesota, was an uncle of a patient that had PKU. And based on that interaction and trying to find something more effective for her, he developed the classic test for PKU. So really at all these points, interventions or interactions with the family have been really important in moving things forward. There's just a bit of a roadmap about what's happened kind of federal level. So the American Association of Pediatrics has been important in trying to unify an approach for newborn screening. HRSA in 2004 created the Advisory Council on Heritable Disorders, Newborns and Children. American College of Medical Genetics was played a key role here too in trying to develop a uniform screening panel, a recommended uniform screening panel that we refer to as the RUSP. There was some legislation that helped fund some of this, and HRSA and CDC were important in that. And the RUSP now has been functioning for a period of time. There's been a number of disorders that have been added to the RUSP over time. In terms of newborn screening, so one of the initial descriptions of what the thought was newborn screening should accomplish was from Wilson and Younger, who worked for the World Health Organization actually, and published some of this in 1968. But they identified certain criteria that we should consider in determining what might be screened for. And they said the primary prevention should be to abolish disease by protecting the individual and population from attack before the challenge, meaning the onset of the disease, has been made. Criteria that they had referred to includes the validity and reliability, which reflect on the test. The yield relates to the prevalence, essentially. Cost of the test. Acceptance is the families that were going to be tested and how well they're going to accept being tested for these kinds of disorders. Follow-up relates to therapy as well. But these are public health programs and they're state-based. So there's a number of infrastructure that needs to be established, sometimes for every disease. And there's a number of groups that are involved to be able to make these things happen. Much of this is appropriating funding to be able to do that. You may have to train additional personnel. You may have to buy additional equipment to do that. And as you might expect, that some of the states who determine what is going to be tested for within their state can vary substantially in regards to what's being tested for. And I want to spend a lot of time talking about this outside to say that the process of putting together a package for consideration for a specific disease on the RUSP is an involved process. So you have to initially propose a disease, a package that's put together to do that. HRSA has only got so much resources to look at these, so they prioritize which diseases they're going to explore. There's a series of votes about moving forward for potential diseases. There's a full review done. They will eventually say yes or no in terms of whether they recommend that this should go on the panel. And then it goes to the Secretary of HHS, who has the opportunity to ultimately say yes or no for adding things to the RUSP. So this is a long, drawn-out process, and the groups involved do a very good job of it, but it still functionally is a bottleneck. So I'm just showing here the status for newborn screening for ALD. So ALD was added to the RUSP in February of 2016. And if I counted correctly, which I may not have, but there's 26 states that are now screening for ALD. And so a lot of the larger states are screening, so it's probably 75% of the kids that are currently born that are tested for ALD. But, again, it's been 6 years since it got added to the RUSP, and there are a number of states that still aren't testing. So, again, why do the discrepancies exist? Different states can determine what they want to have on their panel. But one of the things that, again, is important is that the families can make a difference here. And you don't have to have a disease on the RUSP for a state to begin testing. So Crab-A is one of the prototypes here. So Jim Kelly, who was the quarterback for the Buffalo Bills, had a son who, Hunter was his name, who was diagnosed with Crab-A. He was quite progressed. He died. But the family decided it was important to have newborn screening for Crab-A, and they had enough connections and wherewithal to be able to move that forward. So in New York, they started screening for Crab-A quite some time ago. I think there's upwards of 6 or 7 million kids now that have been screened for Crab-A in New York. But I think there's only totally about 8 states that are screening for Crab-A, and it's not yet on the RUSP. We talked about ALD a bit, and the Super Gav Act I wanted to talk about a bit. So there's a boy that was diagnosed, Gavin, who had MLD, and he was diagnosed at 3. He had juvenile onset MLD. He was transplanted here. He developed interstitial pneumonitis, and based on his issues related to that and his weakness due to his underlying disease, Gavin died. But his parents, Nick and Shauna Quimby, decided they wanted to do something to minimize the impact of leukodystrophies in Minnesota. And they worked with their Senator Jeremy Miller to create the Super Gavin Act. And Dr. Miller, or Senator Miller, wrote the proposal, which got passed by the state. And Minnesota was one of the earlier states to begin screening for ALD in this case. Again, MLD, we didn't have the opportunity to screen for, and we still don't actually. But the family was instrumental moving this forward. So, and Gavin was quite into the superheroes, as you can tell from the picture. So we've got his kind of Clark Kent transformation there in the upper right. And then also importantly, the family and other families have through their advocacy created fundraisers that have helped us and other groups try to move forward the field in terms of the leukodystrophy. So we thank the families for that. The Quimby's have been very important in this, but Chloe's fight, which was for MLD. I actually talked to the director of Cure MLD last night, who called me about a patient. So these advocacy groups are really helpful and important in moving the field forward. And just to demonstrate in terms of the newborn screening, how much difference that makes in terms of diagnosis. So these patients essentially within a week or two of birth are identified. The primary pediatricians are informed of this. The geneticists generally as well. They can get in very quickly, confirmatory testing done, and you can make the diagnosis. So within weeks or even days, you can establish a diagnosis in these infants, whereas it may have taken years previously. And I want to expand a bit on ALD, which again is a bit different because ALD is a X-linked disorder. But there are patients that have been picked up by newborn screening here in Minnesota, for instance. And when they come in to see our genetic counselors and geneticists, Sheetha Pillai, for instance, is part of our clinic here, but you can then look at the pedigree and go back a number of generations and identify the number of people that may be affected by the disease. So this ends up being very important. I think about 30 kids have been picked up with ALD since we started screening, but the number of additional patients that have been picked up indirectly from the primary index case is 2 or 3 times what is actually picked up by the screening itself. And I just want to briefly mention, so for ALD, for instance, these kids are normal at birth, essentially, outside of the biochemical abnormalities. But we don't know what issues they're going to run into at what ages. And so we have a multidisciplinary clinic that's been established. Again, our genetics group is involved in that. Brad Miller runs the endocrine side of this. So he screens for adrenal insufficiency. And then as the kids develop, get to the age of puberty, we look at endocrine related issues there. The neurology group has been important. Neuropsychology, Rini Pierpont has been involved in that side of things. And then we see them in terms of transplant too, just to talk to the families about what that would look like should we have to go there. So the comprehensive clinic is actually really quite taken off. And there's not only the patients from Minnesota that are seen there, but there's patients from, I think, 8 or 10 different states that actually come here for the follow-up because they recognize our expertise and commitment here. It also serves as a research tool. So the ALD National Registry is centered here. Ashish Gupta runs that. There's a biorepository that is part of this. Troy Lund is responsible for that. We're now storing MRI images and looking at how we might follow those in these patients on a longitudinal sort of basis. And we're partnering with the Masonic Institute of Developing Brain to be able to do that. And all the data analysis is done as well. Igor Nestersil is interested in the imaging, as is Rini, and so they're working on those aspects of things. And I mentioned Rini's also doing the neuropsychology research here. So this is a large commitment by the institution in a number of different specialties to be able to offer the best therapy and to better understand the disease process. So transition here into discussion about therapies. As you might expect, all these diseases have identified that genes have been cloned. There is the potential to make enzyme, a recombinant enzyme, for instance, but those are large molecules. They don't penetrate through the blood-brain barrier very well. So the utility of that has not been very good thus far. So, how can we treat these patients that have demyelination due to toxicity of the substrate to leukodendrocytes or Schwann cells? So this goes back to 1968, and Liz Neufeld's group was really instrumental in this. So the story here, as I understand it, is they had patients with lysosomal disorders, Hurler patients, Hunter patients. They had fibroblasts in culture. One of the lab techs or grad students, I'm not sure which, actually mixed the cells together inadvertently. And they showed that the substrate accumulation and the lysosomal expansion reversed when you put the Hurler cells and Hunter cells together in culture. And to their credit, rather than saying, "Oh, I screwed up and I'm going to throw this flask out," they said there's something important going on here, and they explored this further and showed that if you have either normal cells in culture with Hurler cells or Hunter cells, again with lysosomal disease, that the accumulation of substrate is essentially eliminated, and that even if you have Hurler cells and Hunter cells, they can correct each other. So this was termed cross-correction. And this was actually the basis for which transplant was explored beginning back in the 80s. And the thought was that you can establish blood-producing cells that are a source of enzyme throughout the life of the patient. These cells will be able to circulate through the body, provide enzyme, and treat these diseases. And as I mentioned, there's enzyme therapies that can be developed, but there's an opportunity to treat the central nervous system, for instance, with transplantation. And essentially, the way we think this works is there's donor cells that have an opportunity to provide enzyme. The enzyme is picked up through a mannose-6-phosphate receptor on the cell surface, and the enzyme is actually shuttled into the cells. But on in the central nervous system, for instance, if there's nerve cells that are missing enzyme or leukodendrocytes, some of the cells from the donors have the opportunity to cross into the central nervous system, into the brain parenchyma, and again, can make enzyme that can be delivered to the nerve cells. So we think this is why transplant has the opportunity to treat these disorders and why it's still being used for that purpose. Just very briefly, in terms of the process for transplant. So if we find a patient that we think would benefit from transplant, we have to get HLA typing. We have to find a donor. If there's full siblings available, we certainly start to look at those patients or those siblings first as a potential donor. In terms of HLA matching, there's a 1 in 4 chance any sibling is going to be fully matched. And even if they are matched, they may be carriers. And if they're carriers, that may not be suitable as a donor. So in most circumstances, we're looking outside the family. We look at unrelated donors. There's about 20+ million people that have been have consented to have their HLA types stored in a database at the National Marrow Donor Program or be the match. And so those patients can be, that data can be screened when we're looking for possible donors. Unrelated cord bloods, there's a lot of stem cells in placental blood. There's hundreds of thousands of cord bloods that have been frozen for this purpose as well. And we can look at those and determine whether a cord blood might be suitable for transplant. There is the capability of using haploidentical transplants now, so using a parent as a donor. Although, again, for the recessive diseases, they're going to be obligate carriers, and so that's not so suitable for the recessive disorders. But for X-linked issues like ALD, there is a possibility of using, for instance, a father in that circumstance as a donor. I don't want to spend a lot of time talking about this either, but generally we look at HLA A, B, C, and DR. There's 2 antigens for each. So we talk about, are you an 8 of 8 match or 7 of 8 match? And again, generally when we're looking at patients, we would screen both the unrelated donor pool as well as the cord blood pool. We have a little more flexibility in matching on the cord blood side, and we can get those cord bloods quicker. This just globally is that process. And we have the HLA typing in hand from the patient that needs to get transplanted. We could do an electronic search to the NMDP. That takes a matter of hours. That's free. When we start actually pursuing potential donor, though, that gets expensive, and that is billed to actually the recipient's insurance. But we have to do confirmatory typing. With the cord blood, that's essentially it. So these are all frozen in liquid nitrogen. You can access this whenever you want them. The unrelated donor circumstance is a bit more complicated because those patients have to, or potential donors, not patients actually, would need to come in and have evaluations done. They have labs done and physical exams done and whatnot. So that and we have to work around their availability, so that timing is significantly longer. So some of these patients where timing really is the issue, we move forward with cords if we have that availability. So in terms of outcomes with transplant, this is MLD. We published, and Alex Boucher actually was the lead author on this, but published our experience with MLD. This is what survival looks like. So most of these patients that died of progression of the disease. And, this is a Kaplan-Meier looking at survival, but it doesn't reflect what the function of these patients are. So transplant may be the best thing we have for MLD, at least for now, but it's inadequate as therapy. And this is national data in terms of the experience with GLD. Obviously, survival is better with transplant than it is without transplant. But a number of these patients, die of progression of their disease as well. So identifying these patients as early as we can ends up being key. For the patients that have infantile GLD, the standard is to transplant them within 4 to 6 weeks of life. So because they progress really quickly. In terms of ALD, this is Minnesota data as well. If we look at overall survival with the patients with ALD, this is what we saw in this group of 60 patients. There is a scoring system that was developed by Dan Less, hence the Less scoring system. And Dan Less is actually a neuroradiologist who's here in Minnesota, but he developed a point system for areas of the brain that are affected by loss of white matter. And so for each area that's affected, you get a point. As you might imagine, the more points you have, the more areas are affected, the more affected you are by your disease. So this is used in stratifying patients in terms of whether they have limited or advanced disease. And if you look at that in terms of survival, and again, this is the same Minnesota cohort, the patients that have less advanced disease clearly do better than the patients that are more advanced. And this is really Pierpont's data, but even in looking at the patients that have less advanced disease, and this is specifically looking at that population, it doesn't mean these patients are not affected. So, Kaplan-Meier curves are whether you survive or not, but this is really the functional aspect of things. On the left side, the patients that have more limited disease, so their less score is less than 4. And on the right side, the patients that are more than 4 and less than 10. But here, the patients that have severe impairment are the black bars, and moderate impairment are the gray bars. So you can see that these patients, even though they may not have overt symptomatic signs of their disease, have significant issues. And these are not corrected by transplantation. So clearly, we need to identify, if we're going to give these patients the best opportunity to have a full life and, be able to be independent and employed and whatnot. Identifying these patients early is key. So I want to talk about some of the issues that or opportunities we might have to treat these patients moving forward, and focus essentially on gene therapy for now. So there's globally two different ways. Well, there's a number of different ways to look at gene therapy, but here I'm splitting them into ex vivo gene therapy. Ex vivo essentially meaning that we obtain cells from these patients. They're engineered outside the body. Cells are characterized and then reimplanted in the patient later. So, and in terms of the lentiviral approaches, essentially we're converting an allogeneic transplant using somebody else's cells to an autologous transplant where the blood stem cells are obtained from the patient, engineered with the gene that provides the missing gene product, and then the patients go through an auto transplant as opposed to an allo transplant. In vivo therapy, at least for now, adeno-associated virus is really the vector system that people are exploring in terms of treating these types of patients. In this circumstance, the virus is injected directly into the patient. And for the trials that are ongoing now, it's delivered into the cisterna magna and then distributed through the spinal fluid through that mechanism. So in this situation, the patients may need to be on immune suppression for a period of time because there can be some immunologic response to the vector system. So talk briefly about the experience thus far for each of these diseases. So again, this is the protocol for the ex vivo lentiviral based approach. So we need to do mobilization of these patients. So they get G-CSF, Pelixifor. The blood stem cells are then released from the marrow. They can be obtained through the blood. Those cells are collected. They're sent to be engineered. The manufacturing piece is actually done by the company. So they're transduced with the lentiviral vector. Then generally the cells are frozen. They're characterized to make sure that the manufacturing process went the way we anticipate it should. Once we have the move forward approval, then the patients come back, they get myeloablative chemotherapy because we still have to eliminate the hematopoietic cells that aren't making enzyme, or in the case of ALD, ABCD1 expression. So they still need to get chemotherapy, but then they're infused with their own cells as opposed to somebody else's cells. And the concept is that some of these cells are going to make their way into the brain and provide benefit. So there have been 2 trials that have been done with ALD. These trials are now closed. This is actually being actively reviewed. So the FDA is actually here in the room next to my office reviewing our data for potential approval of gene therapy for ALD. So this is fairly advanced. But just to show a little bit of this data, so this relates to the LES score I talked about before, what the MRI scores look like and how this has been characterized over time. So many of these patients tend to be quite static in terms of their MRIs. Some of them certainly have shown some progression. If you compare that population of patients that have been treated with gene therapy and compare them to a group receiving allotherapy or somebody else's donor cells, survival, at least in the short term, looks better with the gene therapy. And this isn't too surprising because in the circumstance where you're getting your own cells back, we don't have to worry about graft versus host disease. We don't have to worry about graft rejection. Patients don't need to be on immune suppression. So it's a much more straightforward transplant to do. And the number of complications that we see with allotransplant are obviously significantly reduced when we use an auto approach. However, if you look at some of the additional data, so this is, again, LES score changes over time, comparing the blue is the ALD 102 population, so that's the gene therapy population, and then the black bars here are matched allogeneic patients. And as you can see, the progression seems to be higher. And this is actually statistically significant, that showing that you may actually have more progression with autogene therapy than you do with allotransplant. So this data is still maturing, but so we're going to have to better understand the relative risks in terms of safety and the trade-offs in terms of efficacy. In terms of late complications, there are several patients that have progressed and were taken off the study, off the gene therapy studies for progression. One of those patients progressed quite quickly, was not offered transplant. He died. 3 other patients have been transplanted. 1 died after allotransplant. So there was therapeutic failures on that end. And interestingly and importantly, myelodysplasia was identified in 3 cases now on the ALD trial. So the thought there is that the viral integration has resulted in clonal expansion of populations of cells in these patients, and essentially you have a pre-leukemic situation. So these patients have gone on to require allogeneic transplant for their myelodysplasia. So this is something else that's being watched very closely in terms of the gene therapy side of things. In terms of globoid cell leukodystrophy, the interventions here are primarily with AAV. And so again, the virus is delivered actually into the spinal fluid through the cisterna magna. The idea is the virus is then going to distribute through the CSF into the rest of the brain parenchyma and provide a source of enzyme. So there's 2 trials that are now up and running in terms of use of AAV for globoid cell leukodystrophy. One of those is in association with transplant, and one is treatment with AAV alone. So it's too early to have any data here, but trials are underway. In terms of MLD, so there's been studies ongoing, they're almost 10 years old now, I think, in Milan, Italy. They developed the vector system to do this. And there's a significant amount of data here in regards to the outcomes with gene therapy. And then, in my view, looks really good. So the FDA decides what should be licensed in the US. The EMA decides what gets licensed in Europe. And this treatment, which is OTL 200, is now licensed in Europe for therapy. So there are patients that are receiving gene therapy for MLD in Europe as part of a licensed cell product. But here, this refers to the motor impairment on the kids that were treated with gene therapy versus those that weren't treated. There's a gross motor functional measure, which again looks at motor outcomes in these patients. And so there's a cohort that's late infantile patients that were asymptomatic that were treated. You can see the data there. And there's some juvenile patients that were treated as well. And, again, I think the data looks quite compelling. So just to summarize the gene therapy side of things, there were 2 international trials that were done. 67 patients were treated in, I think, a total of 8 different centers. Actually, 21 of those patients were treated here. So that's under review by the FDA, and maybe in the next 6 to 8 weeks, that may actually be approved. Globoid cell leukodystrophy is just getting off the ground in terms of gene therapy. As I mentioned, there's several different trials that are currently open, but I don't have any data to share with you. MLD is much more advanced in terms of potentially using that as a licensed therapy. It's important to understand that all the patients that have been treated on the clinical trials thus far have been treated in Milan. So there have been patients that were from the US that went to Milan for therapy, but there have been no trials open here. We've been very interested in being able to offer this, so we worked with the company to be able to do that. And we now have at least the ability to treat patients on a compassionate use basis. So the only patients have been treated within the US have been treated in the last year here. And hopefully, if this gets licensed in the next year or two, that we will be the primary site for offering this therapy. So in terms of global questions, allotransplant, there's mortality of 10-15%, maybe somewhat higher depending on your donor status. With autologous approach with gene therapy, it's going to be much less. So the early safety issues certainly favor gene therapy. Whether it will prove as effective for diseases like ALD remain unclear. There's certainly issues related and concerns related to myelodysplasia as well. So that data is going to mature over time. So again, safety issues end up being key. And then there's whether the transplants is going to end up being more or less effective than gene therapy is also going to be a key focus. And I don't have a lot of time to talk about this necessarily, but one of the issues we're going to have to deal with is some of these products are going to be $2 or $3 million, and we're going to have to figure out how patients are going to be able to obtain these therapies. So last slide, I'm going to stop here. Again, these are progressive lethal diseases. Early diagnosis is key. Transplant may be the best we have for now, but it's inadequate in my view, and we need other things to be able to offer. So thanks very much for your time. And hopefully you got a few minutes for questions here.
I can't believe you're showing a winter picture. Why would you do that?
I don't know, I took that picture quite a while ago and it's like, oh, this and that. Yeah, I need a summer picture. You're right. Maybe a fall picture would be good.
It is very beautiful. Well, there's still red leaves on those maples, so it is probably a fall picture, but that's Minnesota for you. For those in our audience, go ahead and put a question in the chat or in the Q&A. I am curious about support for families when if you covered this while I was in transit, I apologize, but support for families when they receive a new diagnosis, particularly a newborn screening diagnosis where their baby doesn't have any symptoms. What does that look like here? Do we have a team, and is there kind of a standard package of support?
Yeah, we've tried to develop that here. I think we've been more successful than a lot of places. Of these diseases, the ALD group is the one that we really have active newborn screening for. So we've got a pretty effective clinic now, a multidisciplinary clinic that we can shuttle the patients to. At least here in Minnesota, most of the patients come to us, and so it's relatively straightforward to kind of get them in the system. But in some of the other states, I think California, for instance, may have 12 different sites that these patients may be going to, and trying to kind of unify an approach and information and support for the families can be really difficult. So these are going to be ongoing challenges, clearly.
Great. And then Dr. Whitley has asked a question that I will try to understand and read out as our last question. Outstanding work, wonderful presentation. Liz Neufeld told me the story about the discovery of cross-correction when cultured fibroblasts from patients with Hurler and Hunter symptoms were inadvertently mixed. She said they were planning to do the experiment eventually. How is cognitive outcome in the European MLD gene therapy parallel to presentation of motor function?
Yeah, that's an important question. It looks like these patients globally are doing very well. So they are accepting patients with late infantile disease if you're asymptomatic, and the very early symptomatic juvenile patients. So, but again, I think it's very clear that you have to catch these patients early in the course of the disease and intervene, because if they start to progress at all, we've really missed our opportunity. But yeah, the paper I was kind of referring to is in the New England Journal in the last year or so. yeah, if you want to get a little more into exactly what those outcomes are, that's all there.
Dr. Whitley also pointed out some cost differences with enzyme replacement versus gene therapy. And then Dr. Ebens was asking about if any of the gene therapy trials are utilizing overexpression approaches. CRISPR targeting of promoters combined with providing the missing gene might be beneficial compared to allogeneic transplant.
Yeah, so the overexpression issue ends up being kind of an important one. So in the lysosomal disorders, CRAB-A and MLD, we think the more enzyme you can deliver, the better off you're going to be. And so the promoters that are used in those vector systems, can overexpress the enzyme. And so they may provide more therapeutic benefit than transplant, because transplant expression is just going to be whatever the normal donor-derived cells are going to make. So I saw one of our patients that was on that gene therapy compassionate use treatment last week, maybe. And his enzyme in his blood is 4 times normal. So at least for those disorders, overexpression is going to end up being important. ALD is a little bit harder because it's not a free-floating enzyme like it is for GLD and for MLD. And so that gene product is actually bound in the peroxisomal membrane. And so whether overexpression really helps in that circumstance is less clear. So, and unfortunately, we don't have a good model system. There's a mouse that's an ALD mouse, and they biochemically look like kids, but they don't get the cerebral disease that the patients do. So, it's been difficult to make a lot of progress in that sort of mode.
Great. Well, thank you so much for such a outstanding overview. Please make sure to evaluate today's session. That Google form is linked in the chat. And I hope you all are remembering that you can get American Board of Pediatrics MOC Part 2 credit for grand rounds as well. You have to go to your CE profile page on the U of M and answer 2 questions. But you can keep trying until you get them right. So it's pretty much guaranteed credit. So I encourage you all to take advantage of that as well. Thank you so much.